Well, this is new for the Mental Health Interest Group, where I am currently presenting from Stellenbosch. So yeah, hello to the Pietermaritzburg-based Mental Health Interest Group for KwaZulu-Natal. I am excited to, in this way, be present with you to present on a journal article for today's in-service session. So really wanting to capture something of the current situation in KwaZulu-Natal, and to see that actually we are dealing with a story that has been relevant for quite a while in our province, looking at resource allocation and funding of our mental health services. So I'm hoping to clarify a bit on that today. Right, so the title of the journal article is Mental Health Services Funding and Development in KwaZulu-Natal, A Tale of Inequity and Neglect. And this has been written by an author, Jonathan Kenneth Burns, who it seems like is very passionate about transformation of healthcare, especially mental health care in KwaZulu-Natal. So he speaks with political language. He speaks about transformation, and really the power struggle, and really recognizes the discrimination that is historically in place due to the apartheid years. So he speaks from quite a broad context, which is very interesting. So he wrote this article, published this article in 2010. I'm also going to be looking at a couple of other articles that say this similar things and create a background for this particular article. So I want to start by highlighting a few points. The one is that this talk really looks at the priorities or values of government and mental health care practitioners. It looks at the commitment of government. It looks at resource allocation and effective and efficient service delivery. So remember those key terms. So to start off, I read a very interesting article in The Plain, published in the Mercury, a big shot in the arm for poorer countries, and speaks to the World Health Organization's appointment of the new leader, who is really meant to, the African leader, Tedros Ghebreyesus, who is hopefully going to really represent the needs of the middle and lower income countries, and healthcare services in those countries. So in this article, it really highlights that globally there's poor prioritization of treatment of non-communicable diseases, insert brackets, neuropsychiatric conditions, and there are financial constraints and poor resource allocation. In this article written by Sanders, it highlights that non-communicable diseases are the top cause of death in lower and middle income countries. Internationally, healthcare priorities are expressed through the resource allocation and financing of healthcare services. So Sanders indicates how low human resources, limited health workers, and limited financial contributions thus do not address the needs of the vulnerable, namely the poor majority. So globally, sustained investment in health is required. So from this we can really see that there is a large population globally that are not accessing healthcare services, and there is a drive from the World Health Organization and within its structures to really advocate for the needs of the poor majority. Then also in a Support statement that was released in February 2017 that addressed the recent Esidimeni tragedy, where there was gross neglect and unnecessary loss of life of mental health care users. This statement highlights the real consequences of upholding financial priorities above humanitarian priorities, where vulnerable mental health care users, those with high levels of relapse, acute health problems, or mixed disorders, have limited access to community-based rehabilitation and are treated as objects rather than persons with dignity. And the serious implication is death, loss of life. In light of this needs to be considered in the history of South Africa, with the recent progressive and transformative legislation, namely the Mental Health Care Act, number 17 of 2002, where local and national government's role was highlighted as being a key duty bearer, upholding the rights of mental health care users, ensuring funding of care, treatment, rehabilitation programs, and ensuring a proactive flow of resources to ensure a high quality of professional services in the mental health field. Mental health care users have a right to this care, treatment, and rehabilitation, so government should be careful not to abandon its oversight functions, especially in resource-constrained settings, like South Africa, which is considered as a middle-income country, and especially KwaZulu-Natal, that has been highlighted as a particularly high-risk province in South Africa. So the consequence to neglect of these functions really cannot be minimized. They include death, disease, disability, and impaired quality of life. And really, the burden of disease placed on the community is massive. So the Mental Health Care Act upholds human rights in light of South Africa's really progressive political transformation that promotes inclusion of all and equitable accessibility to service delivery post-apartheid. And this replaced the Mental Health Act of 1973, which separated mental health from general health care and caused alienation, stigmatization, and disempowerment of persons with mental illness. So the Mental Health Act of 1973 really excluded persons with mental illness from society. The Mental Health Care Act of 2002, compared to the Mental Health Act 1973, was also based on ethical practice, human rights of mental health care users not being inferior to the welfare of general society, and decentralized care, treatment, rehabilitation, and all healthcare providers being responsible towards mental health care services. So they were not only focusing on physical or general conditions, but they were offering more of a holistic approach to healthcare. Everybody having a shared responsibility towards mental health care services. So it should be noted that it is a major concern in South Africa that psychiatric disorders are expected to increase due to the increasing prevalence of social risk factors, being poverty, conflict, and displacement. In another article, which I've included in the bibliography, Mayosi et al. 2009, really confirms the worst, that the burden of non-communicable diseases, which includes mental illness, is especially high in rural areas, that despite transformative legislation and poor implementation, non-communicable diseases is on the increase and risk factors are on the increase. The authors also highlight that progressive healthcare policies need to be implemented by leadership structures, that large investment, financial investment, is needed, and that evidence-based, realistic, effective service delivery is needed in resource-constrained areas. So it should be noted that KwaZulu-Natal and our current context for the treatment of mental health care users really should be considered in light of legislation, considered in light of our socioeconomic status, in terms of the social risk factors, as we consider how to offer effective and efficient service delivery. Many of us are occupational therapists, and so we are heavily reliant on resources for service delivery. So I'm hoping that the article which I'm about to review now is really going to help us understand the situation that we are working in so that we can work smart going forward. So in this article, a mental health gap is identified. It is the gap between major burden of neuropsychiatric disorders and the provision of mental health care services. So there's the need, and then there's the service delivery. And if the need isn't met by the service delivery, there is a gap. So this is referred to as the mental health gap. As the other authors and the same author, Jonathan Burns, have highlighted, there's a history of transformation in mental health care services, especially considering legislation. So the Mental Health Care Act was established in 2002, and then also the UN Convention on the Rights of Persons with Disabilities really was an opportunity where our government, the South African government, aligned themselves with this the UN Convention and committed to offering offering services that met the needs of mental health care users and their community. And there have been efforts towards closing the gap, and closing the gap has really been identified as essential. And ending inequalities is evident in the Mental Health Care Act. This is essential. There are inequalities and discrimination from the past, and this needs to be addressed, especially in terms of the vulnerable population of mental health care users. So in the study that is being presented in this article, the methodology was assessing the budget allocation in KwaZulu-Natal's general and psychiatric hospitals. They are reviewed over a 5-year period, and the resource allocation is compared and contrasted to national norms. Now, these resources include finance, bed allocation, and human resources, those 3 factors. And so we're going to be looking at those 3 elements in more detail just now. The results were that there was a mean increase in budget allocation per annum, so per year, where psych hospitals' budget increased by 3.8%, where general hospitals increased by 10.2%, showing the inequality. The cumulative budget increase for psych hospitals was much lower. Psych hospitals do not comply with national norms, and they achieve 25% in terms of beds and psychiatrists, according in comparison to national norms. That's a quarter of what is required for society. And also what was highlighted was serious staff shortages in northern KwaZulu-Natal. The conclusion of the study was that there's an inequality in funding between the psychiatric and the general hospitals, that there are inadequate facilities, and that there are significant shortages of mental health professionals. There's also very little evidence of government's implementation of the commitments that were made. Right, so looking more in depth, the context really painted by this article highlights a few specific points. So firstly, the burden of disease. Globally, neuropsychiatric disorders are 14% of the global burden of disease. DALY, the disability adjusted life years for mental disorders, is 30%. 30% of DALY consists of mental disorders. Comorbidity. There's comorbidity with physical illness and substance abuse, HIV, AIDS, etc. High-risk behavior, poor compliance with medication, and inability to access care. So these guys are really high risk. There's a low priority despite income level. So across the board, mental health care is a low priority in high-income countries and low and middle-income countries, which is very surprising. Resources, consequently, little attention from government, stunted budgets, and inadequate resource allocation is noted. Millennium Development Goals, the MDGs, mental health is missing. I've noticed this also through the process of the literature review for my research. Despite mental health being a prominent influence on all aspects of life, small budget allocation is experienced globally. So this isn't just unique to South Africa or to KwaZulu-Natal. Now, looking more specifically at the mental health gap, there's a discrepancy between the needs and services, as I explained earlier. The World Health Organization Mental Health Gap Program wants to address the mental health gap, especially in lower to middle income countries. Burns in the Mental Health Gap in South Africa, a human rights issue, highlights the Mental Health Care Act as being an unfunded mandate with grossly inadequate resource allocation. Human resources are also indicated for mental health care in South Africa to be grossly inadequate, with, for example, something that is relevant to us, 0.13 occupational therapists per 100,000 population. This is ironic in light of the significant loss of social and occupational functioning and productivity experienced by persons with mental illness. It's grossly disabling, with persons not having the community survival skills necessary to be integrated into a community and to live proactive lives which are noted to have quality and meaning. Mental health needs and services are forgotten. They have been missed in the planning, strategizing and budgeting in government's health services. This mental health care has not been a key health priority. Right, so then looking specifically, the article looks at mental health in South Africa. It recognizes, as mentioned before, the progressive legislation. It is transformative, yet there has been poor implementation. The poor implementation has led to outdated psychiatric hospitals, staff shortages, and inability to develop tertiary psych services, and undeveloped community mental health services and psychosocial rehabilitation. Mental health reformation. Government has made commitments to radical new transformative approach to mental health care in South Africa. Really, the Mental Health Care Act is phenomenal, as it views persons as subjects with rights who are capable of making decisions for their lives based on their free and informed consent, as well as being active members of society. It also provides a reporting system available to address violations. So really upholding the human rights and ethical practice, human rights of mental health care users and the ethical practice of mental health care professionals. The journal article further looks at the risk for mental illness in KZN, looking specifically at our province. It highlights our population that includes 10 million people. It is considered as a particularly high-risk province, with the highest proportion of persons living under the poverty line, the highest poverty gap. It is second highest in terms of the level of income inequality. It's the third highest unemployment rate in South Africa, the highest prevalence of HIV/AIDS, and the second highest murder rate. So these are all recognized risk factors for mental illness. We should not forget here the political history in our province, the major struggle and trauma that was experienced during the apartheid years between various political parties, and really the particular communities that were most affected by political trauma, crime, violence. There are environmental risk factors, and KZN has many. The quality of psychiatric services really need to be evaluated to address the mental health gap and the burden of disease, looking specifically at the KZN province. Right, so looking at the findings of the study, remember that there were three areas that the study addressed. The first was looking at hospital budgets, the second was looking at hospital beds, and the third was looking at human resources. Now, with each of these aspects, I'm going to be looking at the aims of the study, the findings, as well as a closer synopsis. Firstly, hospital budgets. So the annual budget allocations were assessed over a 5-year period. They were looking then, secondly, at the cumulative budget increase and the comparison with general hospitals. Now, the findings focused on 6 psych hospitals compared to 7 general hospitals. In the 6 psych hospitals, the budget increase over a 5-year period ranged from 8% to 25%. The mean increase was 19%, the mean annual increase 3%. General hospitals, in comparison, had a budget increase of 29% to 64%. Remember, this is compared to the psych hospitals' 8% to 25%. Their mean increase was 51% and the mean annual increase 10.2%. So we can see here that there was a significantly lower median cumulative budget increase for psych hospital as compared to general hospitals in KwaZulu-Natal. In making a closer synopsis, we can see that funding, there was inequitable funding. It's unfair. Psych services received a third of the increase received by general hospitals. There were drops in budget in 2/3 of the psych hospitals compared to no drops in budget in the general hospitals. This really indicates the values of the government. The psych hospital sacrificed to maintain the general hospital services. There was no funding to tertiary psychiatric services as compared to funding for tertiary general hospital services. There was no specific allocation to psych hospitals from the conditional grant meant for the development of tertiary level services. The development of important tertiary level psychiatric services like the child and adolescent units, psychogeriatrics and neuropsychiatry in 2010, when this was written, was not funded at all. There was overspending of budgets for these specialized services at the psychiatric hospital. There was overspending of the KZN budget. So in 2010 there was 6 billion rand over the previous 3 financial years, and we know now in 2017 the KZN Department of Health is in major debt. And so they have not curbed the overspending and have battled to provide adequate budget for psychiatric services today. This is really an unfair situation. Really inequitable treatment of psychiatric services. If we compare the beds of those specialized tertiary level services, there were 4 inpatient child and adolescent unit beds in KwaZulu-Natal, 10 psychogeriatric beds in KwaZulu-Natal, 20 inpatient psychotherapy beds, and there were no dedicated beds to the specialization of neuropsychiatry, dual diagnosis, first episode psychosis, and eating disorders. I would like to quote Burns from page 664 in the journal article. In light of the increasing prevalence of HIV-related neuropsychiatric disorders, the high levels of comorbid substance abuse, and the hidden epidemic of trauma-related psychopathology in both adults and children or adolescents that characterize KZN, this lack of specialized services is inexcusable. Right, so the next element of the study was hospital beds. The aim of this section was to identify the actual beds, so what were all the usable psychiatric beds. They were categorized as acute, medium to long-term and forensic beds, and this was then compared to the national norm for psychiatric beds. After that, they looked at the required beds, so the numbers of beds required that were calculated for that particular population of KZN, and the existing beds were presented as a percentage of the required beds. Right, so the findings. The findings were that there was a marked shortage of acute beds. 25% of the national norms were achieved. A slight shortage of forensic beds, with us being at 80%, and an oversupply of medium to long-term beds, 161%. Some areas, regions, districts were less resourced than others, and particular attention can be paid to northern KwaZulu-Natal. On closer synopsis, the acute beds in KZN, a quarter of the national norms of 28 beds per 100,000. Acute beds are required at a district, regional and psych hospitals for implementation of the Mental Health Care Act, and this was not achieved by KwaZulu-Natal. Northern KZN is particularly limited, and it should be noted that Durban, or the South Coast, was also limited due to the long waiting lists. There's really been noted an oversupply of medium to long-term beds due to historical institutionalization, which is very interesting. The lack of community-based mental health services prevents access to PSR in KZN for deinstitutionalization of long-term patients. So this should be noted that many beds were found in the urban areas as compared to the more rural areas. Forensic beds for care, treatment and rehabilitation of offenders is almost compliant with the national norms, however centralized to one institution, and we can guess which one that is. Problematic due to the expansive rural regions. We must remember the large geographical rural areas within KwaZulu-Natal, and this lack of regionalized forensic services hinders rehabilitation follow-up. It is virtually impossible to offer community-based services that meet the needs of the clients due to the expanse of KwaZulu-Natal and the beds being centralized to Pietermaritzburg, for example, according to this article. Right, so we finished looking at the beds. The third aspect addressed within the study are human resources. So in the study, the aims were to identify the national norms for psychiatric human resources as published by the Department of Health, to look at the existing human resources in comparison to the national norms, and then to look at the required human resources according to the population of KwaZulu-Natal. The findings were quite particular to psychiatrists and medical officers. Psychiatrists, there was 25% compliance with national norms, with 0.38 psychiatrists per 100,000 population. On closer synopsis, we can see that only a quarter of the required psychiatrists and medical officers needed are available. Most are located in urban areas. There's limited psychiatric expertise in the rural areas. There has been some success, though, with 10 to 12 regional hospitals having at least one psychiatrist, and limited subspecialist psychiatrists. For example, 2 forensic psychiatrists who are run off their feet, even to date, 2 child and adolescent psychiatrists in KZN, and they are located in the 2 major urban areas. There has been no comment in the study, though, on occupational therapists and other allied health professionals in KwaZulu-Natal. And this is an essential part of mental health care services. So that needs to be considered as well. Human resource allocation for mental health care services for psychosocial rehabilitation needs to incorporate the whole clinical team. So in conclusion, the study states that KZN is historically and even currently disadvantaged in terms of funding, infrastructure development, and staffing. And we know this from personal experience. There's limited funding for psychosocial rehabilitation. Our hospitals are crumbling. It is not a therapeutic environment.